This topic is very near to my heart, anesthetist as echocardiographer. This is a very important reminder for all of us that comfort is worst addiction. The moment you feel that you are very comfortable in an environment, probably your decline has already started. So somebody will come, somebody will do echocardiography for me, and then I will take my decision based on somebody else's decisions. Probably that is not the correct way. कारण आपल्याला माहिती आहे तूच आहेस तुझ्या जीवनाचा शिल्पकार. So you have to take your own stand for your patients. And when we start the journey as an echocardiographer, this is very important quote, that you start by doing what is necessary. So you start finding the ways, can I get some views, can I have some insight about this patient's heart, then do what is possible. Then you slowly start getting better views. Then you start getting some of the basic measurements. And believe me, once you do that, suddenly you are doing impossible. That means you start in bits and pieces. You will not be an expert in the beginning. You'll have to start slow. You will have to slowly build up your own environment. So if I tell you that within the last month, suppose you have got 6 patients in the perioperative period who had got a 70 systolic blood pressure. So what would be your reaction? Okay, somebody will say I'll give fluid to that patient, somebody will say I'll give inotropes to that patient, but it will be all, most of it will be guesswork without knowing what exactly we are dealing with. But if I show you these images of those 6 patients, probably the picture will completely change in your mind. Okay, that is because for somebody you will give inotropes, for somebody you will give fluid with more confidence. For some of the patients you would like to drain the pericardial effusion or a massive pleural effusion, or for somebody there can be an impending pulmonary embolism, and you might be dealing with somebody who has got a very hypertrophied heart, and your decision making will be entirely different for all the 6 patients. So probably you can open your third eye with the help of echocardiography, or for that matter, point of care ultrasound. So what is the essence of point of care ultrasound? So you have to always do it in conjunction with the physical examination. The POcus question cannot be go and assess heart of this patient. That can never be a POcus question. POcus question is this patient hypovolemic, yes or no? Because you have a question in mind, clinical question in mind, and you are trying to find the answer, and most often the answer is either yes or no. So is this patient having pericardial tamponade, yes or no? So that is what you are likely to achieve with the help of POcus. And POcus is performed by physician who is in charge of the patient irrespective of his specialty. He need not be a cardiologist, or he need not be a big time intensivist, so he should be able to do it. So what is our aim, or where we are as an echocardiographer doing fate examination as anesthetist? So we are at this base of this pyramid. So we can acquire standard TTE views. We can recognize major causes of arrest, shock, or hypotension. We can quickly recognize whether this patient should be sent to cardiologist, or we are good to go ahead with surgery for this particular patient. Our aim is never to become level 3 echocardiographer, which is a specialized echocardiographer who can do all invasive and major procedures. So that is never an aim when we are doing a fate examination. So that should be very clear in our mind. So as an echocardiographer, if you are anesthetist, you will be doing mostly a fate examination only, and we should be able to capture this major 6 or 7 important causes of shock and hypotension and start treatment immediately based on these diagnoses. Basically, it can be a pulmonary embolism, can be a tamponade, severe hypotension. It can be because of severe MI or severe hypovolemia. You should be able to diagnose that, or it can be a massive pneumothorax, big pleural effusion, or pulmonary edema. So all these causes you should be able to at least go to a basic differential diagnosis and start treatment accordingly. So why anesthetist as echocardiographer? So this paper is really very close to my heart, because if you see the title, and this has been published in JACE, so focused ultrasound examination by obstetrician. So this is from northeast part of India, in which they trained obstetricians who already had got ultrasound machines to do echocardiography examination for pregnant women. And majority of the obstetrician could very well diagnose many important conditions like rheumatic heart disease, atrial dilation, pericardial effusion. And this was almost similar to what an expert echocardiographer could do. So if obstetricians can achieve this kind of competence, why not anesthetists? So this was a very early paper published almost 15 years back in BJ by Australian team, Dr. David Canty and Colin Royce, and they had done initial audit of around 100 cases of transthoracic or transesophageal echo, which they did in perioperative period. And they said that we could come to various cardiac pathologies, or in many of the cases, like 48 patients, it was absolutely normal scan. So they said that, okay, there's nothing to worry about this patient. You can straight away go for the surgery, or you can completely cancel the surgery, meaning that some patients had critical aortic stenosis and they were just not fit for any surgery, or somebody had a very severe heart failure, so the surgery was very minor surgery and they postponed the surgery for that patient. Or you could postpone the surgery for cardiac referral, get the fitness for this patient seem to have very low EF, can you optimize the medical management and then go ahead surgery? Or you could actually change the surgery, meaning that somebody who was supposed to undergo laparoscopy might have to now undergo open surgery or a quick surgery by a senior surgeon. So there are a lot of changes that they could do. This is another experience of perioperative echocardiography consult by anesthetist. Okay, and what were the important indications to do transthoracic echo? Most of it, almost half of it, was hypotension, which was unexplained. Okay, or it could have been a coronary artery disease, or patients who has known heart failure, somebody had a murmur for aortic stenosis and evaluation. So these are the various typical indications for which anesthetist can do echocardiography. Okay, and then there can be important diagnosis which can be made. So this particular paper published just recently, couple of years ago, from Pennsylvania University, and they said that, okay, almost half of the patients there were no findings, which in a way is an excellent thing. So you can straight away go ahead with surgery in those 50% of the patient. But anesthetist could very well pick up LV dysfunction, they could pick up hypovolemic shock, they could pick up RV dysfunction, aortic stenosis, so on and so forth. So anesthetist could just help of basic training. So this was all anesthetist staff who were trained to do transthoracic echocardiography, and they could pick up various causes of hemodynamic instability, which could be left ventricular dysfunction, hypovolemia, hyperdynamic heart, which can be seen in sepsis, or diastolic dysfunction, and most importantly, with the help of this diagnosis and with the help of these causes of hemodynamic instability, anesthetist could start various treatments like inotropes. They could shift the patient to ICU, additional use of fluid and blood. So it can make a huge difference in step up management. So it can be either step up or step down. As we said that 50% of the patient had got a normal echocardiography. So that can be a step down management. So suppose you have kept an ICU bed reserve, but this patient looks okay. So just step down management, keep that bed for more deserving patients. So it can happen in either ways. It can be a step up management or a step down management as well. So this was another paper in which they have said that the perioperative echocardiography, perioperative rescue echocardiography could change the management almost in 60% of the cases. It can be either intraoperative or a post-operative, in either in post-operative care unit or post-operative ICU. So it can have a huge impact on perioperative management of various patients. So we should be learning echocardiography not only for sake of our passion, but it can actually have the impact. So all these evidences which I showed probably can have a huge impact on perioperative management. And as Sujit sir had said, that we could contribute to American Society of Regional Anesthesia POcus Spotlight series by this advanced FATE series. And if you scan this QR code, you can straight away go to that particular article. There are various other articles even on basic fate, some other POcus aspects which are very useful. So there is not shortage of any learning material. If you go on internet, you can find many of them. So coming to echocardiography proper, so these are the three important windows in through which we can look at the heart. First is subcostal window, in which you can see the heart from subcostal side, a parasternal, which is just lateral to the sternum, or an apical window where you look at the heart from apex of the heart. So these are basically three important windows, and these are three important maneuvers which you should be knowing. And if you are doing, say, preoperative blocks using ultrasound guide, this should not be a very difficult thing for you to understand, that it can be either tilting, in which you can see the heart antero-posterior direction. So it just changing the angle on which you can look at the heart. It can be right from most anterior to the most posterior structure. If you rotate, meaning that you completely change the angle, and then from a long axis you go to a short axis view. So that is the rotation movement, and sliding is from one intercostal space to the other. So if you learn these basic maneuvers, which is probably art in echocardiography, so you will be able to get majority of the views. So coming to the four important basic fate views. So first is a subcostal four chamber view, very invaluable view. If you don't get anything because of various reasons in a particular patient, this view comes as a rescue view, in which patient is lying supine. You are holding the probe in subcostal plane just below the zipisternum, and the orientation marker is facing to the left of the patient. And what you see is, on the top you see liver, you interrogate liver. Below the liver will be your RV, tricuspid valve, and RA. Then you can see left atrium. You can very nicely delineate the interatrial septum. This view is very good to diagnose atrial septal defects, ASDs. The size of all the four chambers, pericardial effusion, various pathologies you can pick up by just this simple view. This is a very simple but very important. So a little tricky view can be an apical four chamber view, in which now patient is lying in the left lateral decubitus position. You are putting in the probe just below the left nipple, and the orientation marker again is facing to left shoulder of the patient. And if you get a nice vertical image of interventricular septum and interatrial septum, that is supposed to be a nice four chamber view, in which your LA, LV, RA, and RV. So this view, this is an image which is a traditional impact on everybody's mind, that there are four chambers of the heart and all can be seen in one view. So this view is probably very good view if you are communicating with your surgical colleagues. So they can have a very good impact of how the heart overall looks like. Then coming to this parasternal long axis view, in which you are just lateral to the sternum in third or fourth intercostal space, and your orientation marker is now facing towards the right shoulder of the patient. So what you see on the top is the RVOT, then interventricular septum, and the LV. And what you can see is the LVOT and aorta here, and two leaflets of mitral wall, that is anterior mitral leaflet and a smaller posterior mitral leaflet and LA. So this view is very good view to do some measurements, which we will go into details just in a while. So if you rotate the probe, meaning that now you were, for the long axis view, your orientation marker was towards the right shoulder of the patient. Now if you shift it to the left shoulder by keeping the probe at the same place, not moving it at all, but just rotating the probe, what you get is the parasternal short axis view. So this is also known as a donut view, in which you can see the heart in cross section. All the segments of the left ventricle at the mid papillary level can be seen. Also can be seen is the right side of the heart, RV. So this view is very important view for regional wall motion abnormality and overall contractility of the heart. So coming to some cases, this was a 26-year-old female undergoing surgery for ruptured ectopic. So you have given lot of fluid, almost 2 liters. You have given one colloid also. BP is still 70 systolic. So you started noradrenaline, not much of response. So what next? So if you just put the probe in the subcostal window, and if you see the IVC in long axis, okay, you can very clearly make out that this IVC is highly collapsing IVC. So this IVC is collapsing, and sorry, this video is not playing but this was an hyperdynamic LV in which it was purely hypovolemic shock. So even if you have given adequate fluid to this patient, still the patient was hypovolemic. So you need to probably give more fluid. So what important point that I want to emphasize that might be your seniority. Your intuition may not be always correct. So if you see it, to believe it. So if you see the heart, if I say, okay, I've given enough fluid, if the echo is not reflecting in it, so it's of no use. So coming to this subcostal IVC view, which we just saw. So from the same subcostal window, now you got to rotate the probe 90 degrees, and now your orientation marker is facing towards screening. So now you get a nice view of IVC in the long axis. And if you just put an M mode across it, you can see a nice collapsibility or either a full IVC. So if it is a collapsible, which was the case in we saw it, so it was nicely collapsible, in which the diameter is less than 2 centimeter or 21 millimeter. And if it is collapsing more than 50%, the CVP will be definitely less than 5. If it is more than 21 and it is not collapsing, usually the CVP is more than 15. So you need to be cautious about these patients. Another brownie point that you can get from the subcostal view is confirmation of central venous catheter. So you just have put a CVP, you want to immediately use it. You don't have enough time for chest X-ray or something. Just get this subcostal view, get some 4 or 5 ml of saline, aspirate it with blood and give a rapid injection. And if you see this kind of gush, within 2 seconds of putting the saline, you are 100% sure that, almost 100% sure that your central line is in correct place and you are good to use that central line. So this was case happened couple of months back actually. This was the last case of the day. 60-year-old male, hypertensive, was undergoing spine surgery, and patient had hypotension just before making it prone. They were in a hurry, last case of the day, chala patapat monitor kada, just make the patient prone. But one of our colleague was doing this case and he said that, okay, no, just wait, the pressure is 70. So he gave some fluid, there was absolutely no response. Then he gave a bowl of sofmephentermine and so on, but there was not much of response. So he again attached all the monitors and he could see that patient had got some arrhythmias. And that's when we started worrying. So that's how the image was. You can see the heart is just flickering and the IVC was full. With the help of this finding, certainly say that this is not an hypovolemic heart which need. So me and Dr. Pramod sir were there, so we immediately started adrenaline and NTG for this patient, looking at this full eye, okay, and some kind of regional wall motion abnormality. Because it was an emergency, we could not get all the views, but this information was enough for us to guide the treatment. And believe me, with 70 blood pressure, nobody would have started NTG for this particular patient otherwise, if you don't have an echocardiography finding. But this patient immediately had arrest. We needed CPR, we abandoned the surgery, and then we shifted patient to ICU. Patient was stabilized, extubated next day, and this patient actually had tight left anterior descending LAD, 100% was blocked. So they had to do angioplasty and patient was saved. So this not only it can just make a difference of life and death for a patient, and this can particularly be said when you have got unexplained hypertension. So nobody was expecting that this patient may have a coronary artery disease and he may have a completely blocked LAD. So we could just save the day with the help of echocardiography. So how we can actually assess the left ventricle is the most important way is eyeballing. You have to train your eyes. So as you can see here, nicely contracting all the segments, and in the 4-chamber view also, all the segments are coming with the contraction, they are coming nicely. So you will need some time to train your eyes for doing good eyeballing. And to do a good eyeballing, probably you need to get good images also, and then you can. So all of us know that the myocardial blood supply, so you can predict which coronary artery can be involved. So if it is a regional wall in RV or inferior wall, it can be mostly right coronary artery. It is an anteroseptal wall, then it can be LAD territory, and if it is a lateral wall, it can be circumflex or OM artery which can be involved. So if you see this kind of image, where the heart is actually very dilated, very globular in shape. The first one, if you remember, was a bullet-shaped heart. This is a very globular, like a balloon filled with water. So this heart, is straining and it is poorly contracting. If you see something like this, which is a very, very hypertrophic heart, so you can see the contractility is good, but the heart is very much hypertrophic. So suddenly these important findings come in your mind, whether this guy has got uncontrolled hypertension, whether he has got aortic stenosis or hypertrophic cardiomyopathy. So all these things immediately come to your mind just looking at these images. Okay, so coming to some important measurements, because anesthetists are always good in doing some measurements and acting on it. So this parasternal long axis view, if you just put an M mode across it, you will see images like beads. So this is the end systolic, where the LV cavity is the smallest, and end diastolic. So you just need to do the measurements, the end diastolic and end systolic. So you get what is called as fractional shortening. So this fractional shortening, ejection fraction is nothing but 2 into fractional shortening. So that is how most of the cardiologists measure the ejection fraction in the parasternal long axis view. Or you can just get an apical 4-chamber view and pass in the M mode at the lateral mitral annulus, and what you again see is this troughs and nadirs. So between end diastole and end systole, if you measure, so this can be important or a very simple measurement known as mitral annular plane systolic excursion, or MAPSE. So any value which is more than 12 is indicative of a normal LV systolic function. Or again, if you go back to the plaques view, but remember we measured the ejection fraction in the mid segment. So if you just pass the cursor at the mitral leaflets, so you get this kind of signature tracings of mitral wall. This is AML tracing, and below is the PML tracing. So this difference between E point of this tracing to the septum is known as EPSS, or E point septal separations from septum to the E point. And if the value is more than 7, it indicates LV dysfunction. Here you have to know that if the mitral valve is just coming very near to the septum, that means the heart is good. If it is struggling or not going near to the septum, that means heart is dysfunctional. Okay, so and we could demonstrate this in this paper which is published in Annals of Cardiac Anesthesia, that if anesthetists can do this screening of EPSS, they can very well differentiate between a normal and dysfunctional heart. So it is very simple measurement, and you can very quickly learn this measurement just with, I think, 5 scans if you can do, and you will be able to diagnose important pathologies. So, but what American Society actually gives a gold standard is the ejection fraction by volume method, but it is not very commonly followed. But now with the help of technology, we have got these machines available with this auto EF function. So as you can see here, just get a 4-chamber view and press an auto EF button, and rest all measurements machine will do it for you. So it's just like within 10 seconds, you can know ejection fraction of this patient. So coming to another case, which is a 45-year-old male who is referred for fracture femur due to road traffic accident 3 days ago. Patient is chronic smoker. You know that saturation is 85% and chest X-ray is normal, almost normal. So the orthopedician is saying that, okay, this is just a quick case for me. I have to go somewhere, just induce this patient. But you are not sure about what you should be doing. So if you do an echocardiography for this patient, that is what we noticed. Can you see something? The RV is much bigger than LV. You can see that, and RV is almost forming the apex of the heart. And when we measured this TAPSE, which I'll just show you, it was reduced. So what this patient had got an impending pulmonary embolism. Okay, just couple of hours after this, the patient had got this, which is a classic D sign, which is seen in pulmonary embolism. So we could pick up pulmonary embolism in this particular patient. Most of the times, remember that pulmonary embolism can be a post-mortem finding. You just don't know, and patient just goes spirally downward, and you are not sure what is happening. But here again, I would like to remind you that the POcus examination should be always done in clinical conjunction. So you know that you are already suspecting based on the history that this patient can have a pulmonary embolism, and you are just documenting that with the help of echocardiography. Okay, so how do you see for the RV function, whether it is dilated, that is RV is bigger than LV and RV is forming the apex of the heart, or you can pass an M mode cursor on the tricuspid annulus and you get this kind of tracing, and that is tricuspid annular plane. So for the left side it is MAPSE and for the right side it is TAPSE, and any value which is more than 16 is indicative of normal RV systolic function. So coming to another important aspect of which we always are worried is pulmonary hypertension. So the perioperative risk increases from 2 to 45%, whether you are dealing with a mild pulmonary hypertension and you are doing non-emergency surgery, the risk is double to 45%, where the risk if the patient is undergoing a major surgery and patient has got severe pulmonary hypertension. So almost half of the patient will not make it. So this is very important to diagnose this. Can we do it? Yes, definitely we can do it. Just get good four chamber view, align the color flow on the tricuspid valve. If you can see this is a leaking valve. There is a nice backflow which is coming. If you just put a continuous wave Doppler across it, this particular patient had gotten TR velocity of 4.75 and his RVSP was 100, and we were already the patient had got a CVP, so his PA pressure was 115. The blood pressure at that particular point of time was only 90. So this patient had got a suprasystemic pulmonary hypertension. So this patient actually had come for a mitral valve surgery. So we requested the surgeon, please optimize this patient before we take up. So patient underwent high dose of IV Lasix, and then before surgery the PA pressure was just 50. So we can optimize the particular patient and then take the patient for surgery. So can we measure cardiac output, which is another important aspect of echocardiography measurement? Yes. So cardiac output is nothing but volume, which is given by the formula area into length. So how can we measure the length? So we actually get a four chamber view, and if you do just little bit of tail down maneuver, you can see the LVOT appearing here, and then you put a VTI across it, a pulse wave Doppler across it. That's how you get the length. So VTI is velocity time integral. It is nothing but a distance. And how you can measure the diameter? By doing it in the Planck's view. So diameter is area is pi r square. So that's how you get the area from the LVOT diameter, and you can measure this LVOT VTI and nicely you can get a cardiac output. And if you put a body surface area, you will get a cardiac index also. So how can we say that this patient is hypovolemic? Because volume assessment is very, very important aspect. So first is IVC collapsibility. If it is more than 50% and the diameter is less than 2, so in a spontaneously breathing patient, then we say that patient is hypovolemic. If the patient is mechanically ventilated, it is usually distensibility. And if it is more than 18% of distensibility, we say that patient is hypovolemic. In the parasternal short axis view, if you see an end diastolic area which is less than 5.5, so we can say classic sign as kissing ventricles, then the patient is hypovolemic. And remember that if the end diastolic area is good, but the end systolic area is very, very less, that means this patient is having a septic kind of situation or a very low SVR. So that also we can diagnose. So we can differentiate whether this is a hypovolemic shock because of bleeding or because of sepsis. That's how you can differentiate. Or if you can see LVOT VTI, which is less than 15, again, it raises a suspicion that patient will be hypovolemic. And if you do a passive leg raising, just measure the LVOT VTI and do a passive leg raise. And if the LVOT improves by 10 to 20% variability, then patients are usually fluid responsive. So coming to another important aspect, these were the two patients who were posted for major Whipple surgery. Again, the post-induction BP is 70. So first patient is actually a 72-year-old female who has got no comorbidities with normal ejection fraction. And the second patient is also having normal ejection fraction, but he's a hypertensive and a chronic smoker. Can you differentiate between the two images. Although the ejection fraction is normal, this patient on the right side has got a larger LA. So LA is dilated in this particular patient. And the moment you have got some history, that patient is a chronic smoker and hypertensive with a dilated LA, always you think of diastolic dysfunction. So in which patients you will suspect diastolic dysfunction is elderly. Classic symptom is dyspnea on exertion. Somebody who is having systolic dysfunction always raises suspicion whether this patient has a diastolic dysfunction or not. Long-standing hypertensive diabetic patient, history of IHD. If you see LV hypertrophy on ECG, always see for echocardiography for the LA enlargement. So all these patients, you will have a high suspicion of diastolic dysfunction. So why it is important to know the grades of diastolic dysfunction? This slide is probably most important slide of the presentation, because if you have initial grades of diastolic dysfunction, that is impaired relaxation or grade 1 diastolic dysfunction, these patients will be preload tolerant. They will have a low or not be time dependent. So what you can do is you avoid tachycardia in this patient. So allow some filling time. You give some fluid to this patient, maintain sinus rhythm, and they should be doing well. In contrast, if somebody has got an advanced grade, that is grade 2 or grade 3 diastolic dysfunction, the pathology is reduced to compliance. So this patient will be absolutely preload intolerant. They will be very well afterload tolerant. So if you see a patient who has got a grade 2 or grade 3 diastolic dysfunction, probably you would like to start, if they are going in hemodynamic instability phase, you would probably have very low threshold to start inotropes for this patient or vasoconstrictor. You will have to avoid bradycardia and maintain afterload, that is you start this inotropes or vasoconstrictors. Okay, so how do you do an apical 4-chamber view? Just put a color flow across it, and what you get these classic signs of E wave, the deceleration time, and A wave. So this A wave actually corresponds to the P wave on the ECG. So you measure this E by A ratio, and there are classic signs of this EA. So in normal patient, the E will be bigger than A. Okay, in the initial grades of diastolic dysfunction, in a mildly impaired, the E will be smaller and A wave will be bigger. As you progress, so this is again E wave is bigger. So this is moderately impaired, but what we call it as pseudo-normal pattern. Okay, so in normal and pseudo-normal, the E wave is bigger than A. Okay, and in severely impaired or grade 3 diastolic dysfunction, E wave is almost double than that of A wave. So how to differentiate between this normal and pattern? So you need a tissue Doppler to differentiate between a normal or a pseudo-norm. If the patient has got E prime, which is less than 10, or E prime septal less than 7, then we can definitely say that this patient has got a pseudo-normal pattern. Okay, so there are various numbers on which you can act, but these are the two important aspects. If you remember these two, you can probably solve most of this puzzle of diastolic dysfunction. You have got a E by A ratio which is between 1 to 2, both normal and pseudo-normal. But now in patients who have got a normal diastolic dysfunction, the E prime will be very high. E prime will be normal, and here in the pseudo-normal pattern, the E prime will be small. So similar mitral inflow velocities, but different tissue Doppler velocity. In a mildly impaired patient, you will have a smaller E and a bigger A. In patient who have got severe diastolic dysfunction, it will be very high E and a small A. So if you just remember these two figures, then probably most of the diastolic dysfunction you can do it by yourself. And definitely this is very, very important, because HFpEF or heart failure with normal ejection fraction is an important entity which you can pick up. There are various numbers, but these numbers are at times can be confusing. So we have demonstrated, last year this paper was published. So we have demonstrated that if you can see elastic recoil signal, that is between E prime and A prime, if you see a positive deflection, Okay, so this is a very, very important sign to say that patient will have a normal diastolic function. Okay, you have got a positive deflection, which is S prime, which is after the QRS complex. So this is S prime. If this S prime is more than 5, almost 10 in this, but is at this trace of tissue Doppler, I can very comfortably say that this patient has got normal systolic function and normal diastolic function. Just go ahead with the surgery. And as the diastolic dysfunction progresses, this elastic recoil signal between E prime and A prime is lost. And that is what we demonstrated in this paper. So you can literally just look at the tissue Doppler image and you can say that there's no diastolic dysfunction, there's no systolic dysfunction. Okay. So coming to this patient who was a 27-year-old female who is for emergency LSCS, and she had got a balloon mitral valvolectomy 5 years ago. She was lost to follow. Just because BMV was done, you will not rely on it. You just put an echo probe and you can see that LA is massively dilated. You can see LA is occupying almost half of the heart. The LV is very small. The leaflets are not opening well. So we just with this help of image, we could very certainly say that, okay, this patient needs some evaluation, and cardiologist actually said that, okay, this is again severe mitral stenosis, severe pulmonary hypertension. So it entirely changed the anesthesia management. So coming to evaluation of aortic stenosis, which is very, very important. So we do this by IM approach. What is the indication? So an elderly patient who is undergoing an urgent or emergency surgery. Okay, you now hear an audible systolic murmur. Patient may have or may not have some history, but you have a systolic murmur. So that is an indication, important indication in IM approach. So what do you do then? You acquisition, that is acquisition of basic fate views. So you obtain a plaques view, parasternal short axis view, or apical 5-chamber. We'll just see. In the plaques view, you can very well see that the aortic valve is very heavily calcified. It's hardly moving, almost not moving at all. It looks like a bleb of calcium actually. In the parasternal short axis view, we again confirm that, okay, this is heavily calcified aortic valve. And in the apical 5-chamber view, again, we demonstrate the same thing. This is an heavily calcified aortic valve. This reduced mobility of leaflets. Then we do some measurements in the long axis view. First do a color flow Doppler, then we can do continuous wave Doppler, get an information about severity. So this particular patient, if you can see here, the aortic gradient, maximum gradient was 74 and mean gradient of 52, meaning that this patient has got a severe aortic stenosis. So in this IM approach, what now you have acquired the image, you have done some interpretation. Okay, so now based on these images, I know that this is a severe aortic stenosis. How it will help in medical decision making? So you shift the patient for formal thoracic echocardiography, get an cardiology consultation, you adjust the perioperative management, you may step up the hemodynamic monitoring, and you may like to shift the patient to ICU or something. So this is how you can differentiate. So far we know that we can do RA assessment very easily with subcostal IVC view. You can do eyeballing, or slowly you can do some quantification of LV systolic function in apical and parasternal long axis view. You can do a RV systolic function by eyeballing, PA pressure measurement. You can do cardiac output measurement, and you can do mitral and aortic valve assessment. This is just a visual assessment that you can do. So plethora of information. So that is how I said, you start doing what is possible and suddenly you are doing impossible. So now you can with this help of this basic information, you can solve the hemodynamic puzzles in almost more than 90% of the cases. So what we do, I'm actually involved in this US ABCD and PICU Foundation for Basic Fate workshop. So we do Dr. Desurka sir and Dr. Amit Dikshit from Pune. And so far, I'm very happy to say that so far in last 3 years only, we have conducted almost 46 workshops, and we have trained all more than 2000 delegates, on which they had pre-learning module, which was there. So as you can see, right from postgraduates to very senior consultants were actively involved in these workshops, and that's how we could do. Thank you.